Good afternoon, everybody. We're very pleased to have Paula Camargo, Professor Camargo from the Universidade Federal de São Carlos in Brazil here for a Pain in Motion Masterclass. Paula is the coordinator of the Laboratory of Analysis and Intervention of the Shoulder Complex in her university. She has published widely and was the recipient of the 2017 Early Career Researcher Award awarded by the WCPT. Since 2015, she has been the editor-in-chief of the Brazilian Journal of Physical Therapy, and ever since that journal has developed very well and is now one of the leading journals in our field. Today, she will talk about shoulder pain rehabilitation from biomechanical to biopsychosocial approach. Paula, the floor is yours.
Okay, y'all, thank you very much for the presentation and good afternoon. I'm also very honored to be here. Wait, it's not there or not? So I'm very honored to be here, and I want to thank Joe for this opportunity, and I also want to thank Kat that is funding my trip here. So the title of my presentation is Shoulder Pain Rehabilitation from Biomechanical to Biopsychosocial Approach. I will start the talk telling you a little bit about myself, my background, and from where I come from, okay? So I come from Brazil. Brazil is a huge country. It has 26 states plus the federal district. And the capital of Brazil is Brasília, that is located just right here. And we have also a huge population, especially if we compare to Belgium. So we are about 215 million people. The official language in our country is the Brazilian Portuguese. And this is the president. I will not talk about politics, but this is Lula. And this is the third time he is the president in our country. So I come from São Paulo, that is located just right here. Here's a closer picture of the state. You can see São Paulo here. So São Paulo is the capital of the state of São Paulo. São Paulo is the richest state in Brazil. But I come from São Carlos, that is right here. São Carlos, I think it is a very nice city to live because it is full of students. Here you have a general picture of the city with the main cathedral. But the reason it has a lot of students is because we have two public universities in São Carlos. One of them is USP. So USP stands for Universidade São Paulo, that is from the state. So USP is a very huge university, and the campus in São Carlos is mainly related to engineering. So no health-related course in our campus, in the campus in São Carlos. And the other university, just right here, is UFSCar. UFSCar is the Federal University of São Carlos, or Universidade Federal de São Carlos. And that's where I got my bachelor degree in physical therapy. That's where I got my master's, my PhD, and this is also where I work since 2013. So UFSCar has two units that provide healthcare for the population. Here you can see the hospital. The hospital has nowadays 70 beds, but it has a plan to expand to 200 beds in the next 5 years. And this is where most students of the health-related courses do some of their training in the last year of the course. We also have the outpatient clinic. So this outpatient clinic is located in campus. And this is where most of our PT students do most of their training during the last year. So this clinic is a reference in São Carlos and region for rehabilitation. And there we have a multi-professional rehabilitation team. Talking more specifically about the Department of Physical Therapy, the course was created in 1978 in our university. Here you just have another view of the building, and at the department, that's where all the staff and faculty of the PT are located, and that's also where we have all the labs where we do research. So here is another view. And at the department, we also have the graduate program in physical therapy. So our program was the pioneer in Brazil to have a master and a PhD in physical therapy. We have the PhD since 2001, and the graduate program has reached the maximum standards of accreditation in 2017. So it means that our program is comparable to many international programs. And this is why the program supports a lot with international mobility. So that explains why I'm here and why Lucas was here for 1 year. And we're also planning to send some more Brazilians in the coming months. So the program has 5 lines of research, and we are 32 faculty, and all of them have master's and PhD students. So if you just want to learn a little bit more about the program, we have the English version of the website, so you are all welcome to visit it. And when I talk about the Department of Physical Therapy and the graduate program, I cannot leave the Brazilian Journal of Physical Therapy, because the office of the journal is located in our department, and the journal exists since 1996, and I am one of the editors-in-chief since 2015, so it's been quite a long time already. The current impact factor for the journal nowadays is 4.7. There is no fee of publication, and I want to invite you all to submit your best papers to our journal, okay? The best ones. That's what we want. And I also want to take the opportunity to tell in advance that Joe just accepted the invitation to write an editorial series about the management of chronic pain. So I'm really looking forward to it. And I want to thank you once again. Joe, I keep changing. So thank you. And I also want to invite you to follow the journal on Twitter and Instagram. So my line of research has always been shoulder biomechanics. And of course, I have only been able to complete these studies because I have always had a wonderful research team. And this is the current team in the lab, and we were celebrating Christmas last year. Here, another picture, so you may recognize Lucas here, that spent 1 year. We also have Julia. Julia may come next year in February. We spent 1 year. And in September, we are planning to have Linda coming. Okay, so more and more Brazilians. So I want to thank all the research team for their help and the studies. I was trained at UFSCar. I did my PhD at UFSCar under the supervision of Dr. Tânia Salvini. And during that period, I had the opportunity to spend 1 year abroad working at the University of Minnesota in the US under the supervision of Dr. Paula Ludwig. And this is where I learned how to do 3D analysis of the scapular motion. And since that, I have done many RCTs trying to test different approaches and verify if we are able to change the scapular motion in patients with shoulder pain. And we all know that dyskinesis is highly frequent in individuals with shoulder pain. So this has been my main focus on research. I have also done some research with children, athletes, and nowadays I have 2 RCTs based on rehabilitation and the other one on frozen shoulder. And I have just started a project to look at the shoulder of individuals with diabetes. So let's now finally start the talk. Okay, after talking a little bit about myself. I will start this talk about talking about the pathoanatomy model. We all know that this model attempts to identify some tissue alteration and relates that to the pain that the patient refers. However, we should keep in mind that many times this tissue alteration is just the end stage of cumulative multifactorial injuries. So we can have, as for example, alteration in the motor control. You can have tissue loading due to repetitive motion, or you can have any type of tissue stress, and at the end, you're going to have pain and tissue alteration. And when talking about the shoulder, we have some common diagnostic labels, and the most common ones based on the tissue alterations are the bursitis. So we have bursitis, tendinitis, rotator cuff tear, and some labral lesions. So these are usually the most common in the shoulder. And the MRI, as we all know, is the gold standard to identify this tissue alteration. Sometimes we need some surgical confirmation, but we usually use the MRI. And it is of high cost, and we know that's true for many other joints, that the tissue alterations can also be found in asymptomatic subjects. So this study was done in our lab, where we had 123 individuals with unilateral shoulder pain having the MRI for both shoulders. And we just found similar frequency of alterations for both shoulders. So the most common findings were tendinopathy, partial thickness tear, full thickness tear, increased subacromial fluid, acromioclavicular alterations, labral alterations, long head biceps alterations, fat infiltration, and glenohumeral osteoarthritis. And we could only find more frequency of full thickness tear and glenohumeral osteoarthritis in the symptomatic side, only for these 2 alterations. Okay, so for the rest, the frequency was just similar. And how can we identify the tissue alterations in the clinical practice? We usually do the special tests or the provocative pain tests. We have many of them for the shoulder, and that's true for the other joints. I brought here a systematic review that had the aim to identify the diagnostic accuracy for the shoulder tests. And I brought here an example of the MIR test that is highly used in the clinic. So on the y-axis, you have the sensitivity. On the x-axis, you have the specificity. And you can see that the test presents with high sensitivity and low specificity. And that is true for most of the shoulder tests. So it means that the tests lack reliability and validity. Okay. Based on that, the special tests are not special at all, and we should be careful when interpreting the results of the test. So why are the special tests still used if they are not so special? So I have two main answers for this question. The first one is that the tests are very easy and practical to be done in the clinic, okay? And it is still very common that patients and also some clinicians, they want to try to find a tissue alteration as an explanation for the pain the patient refers. So it's easy. However, this systematic review did not recommend the use of the special test based on clinical practice guidelines. But the systematic review suggests that we should assess the psychological factors and also take advantage of a good physical examination. And the other reason that I see is that it's very difficult to change old habits to new habits. Clinicians are still taught how to use the tests, and they do that a lot. And I think this is our challenge as teachers to explain our students the actual value of the test. Okay? So we have an important role on that. In this viewpoint published by JOSPT, the authors discuss a lot about the value of the special test, and I think that's very interesting, and I invite you to read this viewpoint. You know what, Pastor? Go to the picture, but that's Portuguese. It's still about the pathoanatomy model. This model considers the movement impairments as secondary, okay? So for us physical therapists, the movement impairments, that's what will actually drive our treatment approach. And when we receive a patient with a diagnosis as just like as instability, impingement, or frozen shoulder, they can have different diagnoses because of the tissue alterations they present, but they may present similar movement impairments. And that's where we're gonna focus. And that's what we're gonna try to identify what can be the possible contributors to those movements and target them during the intervention. I hope it's not skipping any slide. Okay, so let's now start talking about the kinesio-pathological model. So this is more consistent with our profession. This model is based on movement alterations. So we consider the movement impairments as the cause or consequence of the patient's pain or dysfunction in this model. It directly guides our treatment plan. Here, the pathoanatomic model is not the primary interest, and it may present better relation with the function of the patient. Not going. Okay. Now it is a video. Okay, so I'll just talk about this slide that is not showing up. So that was a video where I had a patient with shoulder pain in the right shoulder, and she was raising her arms in the frontal and in the sagittal plane. And we were able to see that she lacks totally control of the scapula. She doesn't have any control. And that's very commonly seen in these patients. And as physical therapists, we try to identify what can be contributing to that instability in the scapula. So when we talk about altered motion in the shoulder, we think about the scapula because it's very common to find scapular dyskinesis in these patients. And the literature describes very well the 3D motion of the scapula in asymptomatic individuals. So when we raise the arm, so when we just do like this, the scapula is going to internally rotate and do some external rotation at the end range of arm elevation. It's gonna upwardly rotate and posteriorly tilt, okay? And in individuals with shoulder pain, literature has also demonstrated that these individuals, they present with increased internal rotation, so more of this motion, decreased scapular upward rotation, and decreased posterior tilt. So this is dyskinesis. Right. Now that is the sound of the video. When we have these altered movements in the scapula, the possible contributors that we can find are more related to some tightness in the shoulder or to some altered activation. So when we have some decreased upward rotation, this can be related to decreased activation of the lower trapezius and of the serratus anterior. When we have decreased scapular posterior tilt, that can be related to posterior capsule tightness or even decreased activation of the lower trapezius or even the serratus anterior. When we have excessive scapular internal rotation, it may be related to decreased activation of the lower and middle trapezius or tightness in the anterior region of the shoulder, so the pec minor. And it's also very common to find patients with shoulder pain presenting with shrug of the shoulder. So we can say that these patients present with excessive clavicular elevation, and that can be related to excessive activation of the upper trapezius. I'm just not sure the slides are skipping, but okay, let's continue. So, can I just, because it is skipping a lot. Okay, so we know what can be contributing to the movement alterations, but what does the literature say about the physical therapy for these patients? There are many systematic reviews, and all of them agree that exercise and manual therapy play an important role in decreasing the pain and improving the function of these patients. Here we have just the results of one of the systematic reviews, but that's true for all of them, where there is a strong recommendation of the use of exercise as the first-line treatment for these patients. The systematic reviews also support the addition of manual therapy to the exercise to improve pain and function. So which exercise and techniques of manual therapy these studies use and that we use in the clinical practice? I have published these two papers in collaboration with Dr. Donald Newman, and here we discuss the physiological considerations for the trapezius and for the serratus anterior, and we bring some of the exercises that are commonly used in the studies that are presented in the systematic reviews. And when treating a patient with shoulder pain, we usually try to target more activation of the serratus anterior of the lower trapezius, middle trapezius, with minimal activation of the upper trapezius. So I'll just show here some of the exercise that I believe you all know. So here we have exercise to activate the serratus anterior. We have different positions, different types of resistance, and also progression of exercise. In this next picture, we have the tau wall slide that I like it very much because it is more functional and it also highly activates the serratus anterior. The other exercise, they target more activation of the middle and lower trapezius. So there are many different ones. Here I just brought the I, the T, and the Y. So on figure A, you first teach the patient to how to position the scapula during the exercise, and then you can just progress doing the I like this, then the T, and then the Y. So that is the progression for this exercise. You also have the prone horizontal abduction, the sideline forward flexion, prone extension, sideline external rotation, so all aiming the activation of the trapezius, prone scapular setting, and elevation with external rotation. So I like this exercise very much, the elevation with external rotation, but I think it's kind of difficult for the patient to perform. They tend to shrug their shoulders while doing this exercise, so I would suggest to start this exercise later in the treatment. In addition to the exercise that we target more activation of the muscles, we also have the stretching exercise. And the common ones are related to stretching the pec minor. So here you can just stretch unilaterally or bilaterally using the corner stretch. And stretching for the posterior shoulder. So here you have the sleeper stretch, and this is also very used in the literature, this stretching here. I have used many times, but I don't like it very much nowadays because it doesn't stabilize the scapula. So I prefer to do the sleeper stretch if the patient can be in that position. And what about the techniques of manual therapy? So we find many mobilizations and manipulations. For mobilizations, the most common ones are related to the inferior glide and the posterior glide of the humeral head at the glenoid fossa. And for manipulation, the thoracic manipulation was the most common that you can see in the literature. So I brought here different positions and different techniques for manipulation. Okay, so the systematic reviews showed that these exercises were able to improve pain and improve function, but are they efficient to improve or to change the scapular motion? So that's when I started doing some RCTs. I'll just show the results. The first one was published in 2014. This is the technique of thoracic manipulation that we use. So in this study, we just wanted to check the immediate effects. We had the patient performing arm elevation, then we were tracking scapular kinematics. We had the patient rating the pain. We did the thoracic manipulation. So the patients were divided to one of the two groups, the sham, where they just had the same position, but they didn't receive the thrust. So it was just like a hug. And the other group that actually received the manipulation. And then they performed arm elevation again. For the results, we can see that both groups improved in pain with no difference between groups. And there was no difference in scapular kinematics. In fact, we found very little change in scapular kinematics, like 2 degrees. So this is not clinically meaningful. So no difference. So I like to say that patients sometimes just need a hug and they get better. The next study, we want to evaluate effects of stretching and strengthening exercise with and without manual therapy. So both groups received intervention for 4 weeks, twice a week, and we assessed again scapular motion, pain, and function. This was the protocol for the exercise, and the group that received the manual therapy was individualized based on the needs of the patient. Again, no change in kinematics, but both groups improved pain and function with no difference between groups. So I did 2 more studies. So now I want to check the effects of stretching. We first started stretching the anterior region of the shoulder. So the stretching of the pec minor, all individuals had to present shortened pec minor. They did stretching daily during 6 weeks, 4 reps of 1 minute each day. And all subjects received weekly reminders to do the stretching. This was the stretching they were doing, just unilateral. And guess, very surprising, no change in scapular motion, but improvements in pain and function. So now let's go to the posterior region of the shoulder. Again, now we said, let's see if something is gonna happen. So we compared the specific and non-specific treatment for individuals with posterior capsule tightness. So the group that received the specific treatment, they had mobilizations in the glenohumeral, they had strengthening exercise, they had stretching exercise, while the non-specific group just received sham ultrasound. They just stretched their upper trapezius, and they were just doing protraction and retraction. The intervention occurred during 4 weeks, twice a week, and no change in scapular motion again, but both groups improved pain and function, even the non-specific one. So no difference between groups. So after doing these 4 studies, 4 questions came to our mind. Why scapular motion did not change? Is scapular motion a modifiable factor? Are we targeting the specific impaired motion, scapular motion? Are symptoms associated with the scapular motion? Looking at systematic reviews that only analyze studies that use scapular-focused exercise interventions, we came to the conclusion that these studies were not considering that movement that was actually impaired, okay, and that the studies did not consider if the movement alteration was related to the symptoms of the subject. So how can we make a diagnosis based on movement alterations? We can use the symptom modification tests. There are many of them for the shoulder. You can do the tests for the humerus, for the scapula, or you can simply change posture. I think that one of the most common ones is the scapular assistance test. So for this test, you ask the patient to raise the arm and rate the pain. So let's say it was 4. Then I have the clinician to assist scapular motion while the patient is elevating the arm, and ask the patient to, again, rate the motion. If there is a decrease of about 2 points, then the test is considered positive, and it may suggest that the movement is related to the symptoms of the patient. Here's just an example of the scapular assistance test. Here's the repositioning test. Here's just repositioning the humeral head and just asking the patient to change posture and then raising the arm. So having that in mind, we said, okay, let's try another RCT. So at this time, we had as inclusion criteria, shoulder pain above 3 months, pain for more than 3 points, presence of scapular dyskinesis. This was not considered in the previous studies, and all of them also had to present a positive scapular assistance test. The outcomes were scapular kinematics, scapular muscle activity, pain and function, free avoidance beliefs, and mesophobia. Interventions. The patients were divided to one of the 2 groups, so scapular movement training group or standardized exercise group. All individuals received 16 individualized treatment sessions during 8 weeks, twice a week, and each session had a duration of about 45 to 60 minutes. So I'll start talking about the scapular movement training group. In this group, all the patients had an education phase during the first week. This education phase consisted of instructions about proper scapular position and motion, about muscle activation during elevation of the arm, and it consisted of verbal, tactile, and visual feedback with the aid of a mirror, anatomic models, and EMG. So here you can see that we are using the biofeedback to explain each of the motion of the scapula and how to activate properly the scapular muscles. Then they started the training phase. The training phase had the aim to improve scapular movement during arm elevation and during a functional activity that was relevant to the patient. These were the exercises that they were performing, so this is the progression. So they all started with the wall slide, then they changed to elevation with elbow flexion, then with elbow extension, then with a resistance in hands. And again, they were receiving the biofeedback from the clinician and also from the EMG, so they could activate properly the muscles that were moving the scapula. And for the standardized exercise, we have the usual protocol that we were using. So we had the stretching exercise and also the strengthening exercise. And the results, very disappointing or not, but scapular movement training was not superior to standardized exercise in improving scapular kinematics, muscle activity, pain, disability, mesophobia, free avoidance beliefs. So again, we were not able to change scapular motion. What do we know about the test that we used to suggest that the movement was related to the symptoms of the subject? So that was a scapular assistance test. We don't know much about this test, okay? We just had one previous study where we could find that the individuals who had a positive test, they were more likely to present decreased posterior tilt of the scapula, so this motion here. And last year, we published this study where we could find that higher levels of pain catastrophizing seem to be associated with a negative assistance test. So this suggests that the test is not only explained by the mechanical variables, so we need to consider other variables during this test. So possibly individuals that present a painful arm elevation and a negative scapular assistance test and catastrophic thoughts, they may benefit if we add a biopsychosocial approach in addition to the exercise. Okay. So we should look beyond the movement because all the alterations that we see in the scapula may be just related to normal variability. So the movement system here is just we identify better the movement system as physical therapists, but we should also start looking at the environmental and personal factors when considering a patient with shoulder pain. And there are many studies already that has assessed some of these aspects that go beyond the movement, and many psychological factors, they play a role in the perpetuation of pain intensity and function in shoulder pain. This is one of our studies that is now under review. This is actually part of Lucas' thesis. By the way, he's going to defend next week. So this is one of his studies, and we found that patients with chronic shoulder pain and catastrophic thoughts present alterations in social and interpersonal relationships. So I think this is just reinforcing the need to look beyond the movement in these patients. So which prompts, which patient-related outcomes can we use to assess these patients, considering a broader biopsychosocial assessment? We recently published this study where we linked 3 shoulder-specific questionnaires to the ICF. So we used the Oxford Shoulder Score, the SPADI, the Simple Shoulder Test, and the WARC. And the Simple Shoulder Test and the WARC were the questionnaires that had more items linked to the ICF. So considering these 4 questionnaires, we suggest the Simple Shoulder Test and the WARC if you want to have a broader biopsychosocial assessment of these patients. However, we should keep in mind that none of these questionnaires capture environmental aspects. So this has to be further investigated. And what are the biopsychosocial interventions for shoulder pain that we see in the literature? We don't see much. It's kind of difficult to find this type of studies for these patients. So I think we need a lot of research. I was able to find this scoping review. In this scoping review, they could put together, I think, around 11 papers. And the frequency of intervention, you can see here. So most of the interventions were based on the behavioral aspect. And most of them were based on cognitive, and then the other one based on the behavioral. But we should keep in mind that in this scoping review, not all studies were only based on shoulder pain patients. Many of the studies had some mixed populations, but they decided to include because there is lack of studies. So it's still starting to grow this type of intervention for shoulder pain. But I was able to find these 2 studies. The second one was just published this month. These 2 studies are from a group in New Zealand, and they assess the perspectives of the patients with shoulder pain when they received pain neuroscience education. and the results were very good and promising because patients were able to have a greater understanding of their condition. They gained reassurance, they improved the self-efficacy and the coping skills. So this is just starting for the shoulder. So what is next in our lab? We all know that many people will present at least an episode of shoulder pain once in their lives. And if we consider the excessive imaging that these patients get every year, they also get many unnecessary surgeries. There are many studies showing that the decompression of the subacromial space has just similar outcome as compared to physical therapy. So there are many unnecessary surgeries. There is also an abusive use of painkillers and medications for shoulder pain, and many of the patients also receive low-value care when they're being treated. So if we take all this together, this will cause an economic burden in the health system, and it's also a waste of time for the patients. And unfortunately, there is still an underuse of the first-line treatment in the primary health care. Sometimes we can also question ourselves if clinicians are also underprepared. So I think some of them are. And the next project in our lab is to develop and test a protocol based on best evidence exercise associated with a biopsychosocial approach for these patients to be further implemented in the primary health care based on the reality of Brazil. So this is going to be our next study, and I hope we get good results there. And as take-home messages from this presentation, we can say that the tissue alterations do not drive our treatment approach. Alterations in scapular motion may be related to normal variability. Exercise should be incorporated when treating a patient with shoulder pain, and patients may benefit from a biopsychosocial approach. So that's what I had to present. Thank you for your attention, and I'm open for discussion if you have any questions.
Thanks a lot, Paula. That was very clear, and I think the entire story generates a very important message for undergraduate students, but also for clinicians, obviously. So it's very nice to see the evolution in the way you approach things, and the way also the research findings actually allowed you to develop the clinical reasoning process. Are there questions? So people who are following online are free to activate their microphone, activate their video if they like that, and ask the question live. If they are unable or unwilling to do that, they can also post their question in the chat. Paula, you can stop sharing your screen. That's more, that would be better for the coverage. Yes, thank you. And of course, the people in the room are also free to ask questions, of course. But in that case, for the sound quality, it's probably best that you repeat the question, Paula, if that's possible. So I'll take a look at the chat. And of course, people following online are free to speak out loud themselves. Are there any questions in the room? Nobody having questions in the...
a question here.
Okay, good.
even with the sham. So both groups improved. So she was asking if I could find difference in pain, so if patients improved after the thoracic manipulation. So even in the sham group, so there was increase in pain and function, the immediate effects, okay, with no difference between groups. So that's why I said that they just need a hug sometimes.
Yeah. That concerns that again, my mother has been blessed with nervous system, so
yes, that was the discussion.
Apart from that, with pain and ease, I heard that not I don't know, in the clinical part, but at least there we don't avoid that much the stretching part.
Much what?
We don't use the stretching we still using them because on the research we didn't find any.
Yeah, so she's saying that in Spain they don't use that much stretching techniques while I was using, right?
Yeah.
So all the techniques that I used, there are some studies showing that tightness of the pec minor or of the posterior shoulder was associated with altered motion of the scapula. So that's why we were doing the research. But yes, in Brazil, we use not just stretching, but exercise, stretching, and also manual therapy. But not only stretching, no. That's in combination always. Yeah, and if there is need.
These studies compare with general exercise without showing better saw in a lot of these exercise in a lot of these studies that we presented. When we just exercise, we just do really
for scapular motion, you mean?
Yeah, also on the outcomes.
So the question here is that if the patient is just moving during general exercise, confirm that's correct. During general exercise, they also improve. So I don't know any study that has done general exercise for scapular motion, but for pain and function, yes, if they just move, they get somehow better. Yes, there are some studies on that.
There is an online question. From Professor Eleni Caprelli from Greece. Eleni, please.
Hello. Hi, Paula. Thank you very much for your presentation. Thank you, Jo. You said that the next step is to try to find out about a new approach with biopsychosocial approach for your patients with shoulder pain. And my question is, if you're going to find that there are some anatomic, kinesioppathological dysfunction in some muscles, are you going to be in the temptation to change them? Or you're going just to do general exercises? What is your vision? What do you think that is the next step, as you said in your presentation? Or it's going to be a combination?
Okay, so I think I will target the exercise that has shown to create a better balance of the scapular muscles. So I would focus more on general exercise for the scapula and for the rotator cuff, but I would not be worried about the tissue alteration. In fact, when I'm with students in the clinic, I always tell them to forget about the special tests, which they don't like very much because we still teach. And when they come in the last year, they want to do all that we taught them. So they started the special tests, and when we asked, okay, so do you think you'll be able to change a tear that is in the patient? Why don't you focus on the movement? So I will not be worried about the tissue alteration unless it's like a massive tear, then that's another story. Don't know if I answered your question.
Okay, thank you.
Are there any other questions from people in the room or people joining online? If not, I think we can give Paula another big applause for her very clear and exciting lecture. Thanks a lot, Paula, for your lecture.
Thank you for the invitation, Joe.
And
to be here.
It's our pleasure to have you. And a final thing that I would like to share with everyone is the invitation to join our next Pain in Motion Masterclass, which will be after the summer on Wednesday, the 25th of October at 3 o'clock in the afternoon again. And that will also be a very special Pain in Motion Masterclass, because then we have Professor Ann Söderlund from Sweden discussing with us the hot topic of sedentary behavior in chronic pain. So we will start circulating publicity for that next Pain in Motion Masterclass. And of course, it's a long time until the next Pain in Motion Masterclass will take place. So if in the meantime you want to catch up on some of the masterclasses you've missed, that's also possible, because you simply then have to go to the Pain in Motion YouTube channel, and there you can find all recordings from the past Pain in Motion masterclasses, and you will see we'll have there is a diversity of relevant topics available with all very nice and very good speakers. Thanks everyone for joining us, and I hope to see you in the next Pain in Motion Masterclass. Bye.